We're going to talk today about what we do for severe bone-on-bone arthritis that extends through the knee joint. When you have arthritis that goes all the way through a knee joint, our options kind of fall into two general categories. One, we can treat the symptoms, and then the other, we can cure the disease. The first option of treating the symptoms, that includes injections, pain medicine, using something like a cane to try to offload some of the weight, and something called activity modification, which is a fancy doctor word meaning if an activity hurts, we stop doing it. Those sorts of things help for mild to moderate arthritis. Once they get as severe as this, they do get less effective. But their big advantage, they don't involve surgery. And surgery does have some risks. Those are things like infections, blood clots, troubles with hearts and lungs with the anesthesia. Now, to be honest, modern day surgery is thankfully very, very safe, but those are still risks. So if we do have someone who's especially elderly or sick or can't have surgery for some reason, these symptom reducing techniques are what we sort of stick to. The other side, the other option, curing the disease, that does involve surgery. And nowadays we do something called a robotic-assisted full knee. It's the most up-to-date version of what used to be known as the old-fashioned total knee, but there are some key differences. The first of which is it starts off with a CAT scan. So we do a CAT scan of your leg, and from that we can create a three-dimensional model of your individual bone on a computer screen. And then back in my study, I can do a virtual operation where we replace just the very top of this bone, and then we put a wrap around the very end of this bone. And once we have it perfect, we can bring it to the operating room, and that digital surgery can get downloaded to the robot, and we can translate it off the computer into real life. And it ends up looking something a little bit like this, where again the pieces go on the end of the thigh bone and the end of the shin bone, so that you have nice two smooth surfaces to let the knee bend and glide. It's very good at getting rid of pain and getting you more active. When you compare it to the old-fashioned total knee, there's basically three advantages. One, it hurts less to have done. We tell people it's not a walk in the park, still real surgery, still needs real medicine, pain medicine afterwards, but compared to the old total knees, patients tell us they have much less pain. Two, you do recover faster. The third one is the one that really matters in terms of advantages. We have a much higher chance when we're all said and done of you coming back and telling me it feels like my own knee, and that's what we're after, a knee that moves and feels as close to your own knee as possible. Time frame wise, if we ever are thinking about having this done, recovery, you can put all your weight on it right off the bat. So people start out with a walker and get rid of it as soon as they want and move to a cane. You can get rid of the cane the minute you feel comfortable. After a few weeks, most people feel good to drive. At 12 weeks, we let people do sporting activities like tennis, golf, skiing, those sorts of things. 6 to 9 months is kind of the end date. That's when people sort of tell me they kind of feel mentally fully recovered. The chances that you say it feels like your own knee are around 92%. The old-fashioned total knees, just for reference, only about 70% of people were satisfied enough to say something like that. So it's a much higher chance of feeling like your own knee. If you have any questions about it, or you want to talk about further, either in person or online, just let me know, and my staff will be reaching out. But have a great day. I'll talk to you soon.